It's my pleasure now to introduce Sabiha Gati, that you know very well. She is an outstanding scientist. I want to mention that she had a very nice impact on the recent ESC guidelines. She did a wonderful job, and she distinguished herself particularly in the area of valve disease and myocardial disease. And today she's talking about a very challenging topic, which is athletes after myocarditis, what to do, and specifically what a cardiac MRI can add in this assessment. Sabi, please.
Oh, thank you, Prof. And it's a pleasure to be invited to this first CRY Digital Conference. And I will be speaking on the assessment of athletes post-myocarditis. What does CMR add? So the objectives of this session will be to cover the epidemiology and the natural history of myocarditis, the decisions relating to the diagnosis of this condition, the role CMR plays in both the diagnosis and determining prognosis, and then we'll go through how we use CMR to guide decision-making in athletes with myocarditis. So I'd like to start off with my first poll question to the audience. Which of the following is the most effective method of detecting myocarditis? Is it A, cardiac MRI, B, echocardiography, C, serum troponin, or D, viral serology? Please cast your votes.
Okay.
It'll be interesting to see how people vote.
This is very interesting question, also because this is a reflection of what is the perception of the audience regarding the utilization of the cardiac MRI in this particular field. So I'm very, very, very much interested to understand the opinion of our colleagues. By the way, our colleagues joining the session are from all over the world. This is a question that we can try to answer at the end. So now we have a reliable number of replies, and well, cardiac MRI seems to be prominent and quoted in about more than 80%. Just let's wait some more time for the other people. Yes, the poll is closed, and I confirm that more than 80% suggest that the cardiac MRI should be.
Okay. And I would agree, but let's go through why cardiac MR is important in the diagnosis of this condition, and particularly in our athletic cohorts. Okay, so myocarditis is defined as a non-ischemic inflammatory disease of the myocardium. Viral myocarditis is the most common etiology in the developed world. The pathophysiology is mediated through inflammatory infiltrates, and we know based on mice studies that inflammation can be exacerbated by exercise. Subsequently, we identify myocyte necrosis and degeneration, and as I will go on to show you, CMR is probably your most effective and practical method for the diagnosis of this condition. And sequelae of myocarditis includes cardiac dysfunction, myocardial scar, and arrhythmias, and these are considered to be adverse prognostic factors in this condition. The precise incidence and prevalence of myocarditis is unknown. We do know that based on post-mortem studies, it's an important cause of arrhythmogenic sudden cardiac death. It accounts for 5 to 15% of sudden deaths in all young athletic individuals, and it also accounts for up to 20% of deaths in military recruits, suggesting that exercise is an important trigger in this condition. The natural history of myocarditis goes through several phases, including the acute phase of viral replication, followed by the subacute immune response, and finally the chronic phase. And the chronic phase can range from 50% demonstrating full resolution within 30 days, 25% with persistent cardiac dysfunction, and around 12 to 25% with fulminant heart failure. It remains unclear whether most sudden death in athletes occurs in the early, that is in the acute and the subacute phase, or later on in the chronic phase. But factors that are important in the risk of sudden death include a left ventricular ejection fraction of less than 50%, ventricular arrhythmias, and a low cardiac output at presentation. So moving on to the second poll, which of the following statements is true? Is it A, individuals with active myocardial inflammation can be allowed to exercise? Is it B, myocarditis is usually due to an autoimmune disease? Is it C, routine endomyocardial biopsy is conducted in every case of myocarditis? Or is it D, viral etiology is the most likely cause of myocarditis? So,
okay,
straightforward. So please cast your votes.
Yes. Our colleagues seems pretty much focused on viral etiology of the myocarditis.
Okay, great. So I would agree, viral etiology is the most likely cause of myocarditis. Okay. When it comes to decisions relating to the diagnosis of myocarditis, there are three areas that you really need to focus on. One is resting the heart in the early stages of the acute inflammatory process, potential exclusion from intensive exercise in the context of LV dysfunction, and finally, long-term surveillance in athletes with myocardial scar. Currently, there's no single clinical imaging or imaging test available to diagnose this condition. We know that the clinical features in this condition are non-specific and may go unrecognized in young individuals. Troponin levels may only be elevated in 45% of cases of biopsy-proven myocarditis. Viral serology tends to be non-specific with a sensitivity of only 9%. The ECG features in this condition are also non-specific, and you may identify T-wave inversion or some arrhythmias. Echocardiography is really clinically useful in severe cases. Myocardial biopsy is probably your most specific investigation, but is reserved for a limited group of individuals. And as I will go on to show you, cardiac MR is your most useful investigation and informs decisions. So cardiac MR has evolved as a primary non-invasive diagnostic modality in diagnosing myocarditis with a high sensitivity and specificity and diagnostic accuracy. It can detect myocardial inflammation and edema. It can detect myocardial scar and fibrosis. We can identify regional wall motion abnormalities very accurately and assess ventricular function. And it's also great at excluding other causes of chest pain and positive troponin rise. So in cardiac MR, we have the updated Lake-Louise criteria, which have an over 80% diagnostic accuracy, and which now also include T1 mapping and T2 mapping, which are more objective and can quantify the amount of water and scar content. So you require one out of the following two categories to diagnose the condition. So one is myocardial edema, and second is non-ischemic myocardial injury. So myocardial edema is an important component of the inflammatory process, and we identify this using T2-weighted imaging. You can identify it with regions of hyperenhancement visually, or you can also quantify it with prolonged T2 relaxation times. And these techniques are great for the acute inflammatory component of myocarditis. For your non-ischemic myocardial injury, we tend to use T1 weighted imaging, and we are looking for prolonged native T1 relaxation times or expansion of the extracellular volume compartment. These are affected by both intracellular edema, extracellular edema, capillary leakage, and myocyte necrosis. And although these techniques are good for diagnosing myocarditis at different stages, then they're less specific for the acute inflammatory process. The third type of sequence you could use is your late gadolinium enhancement, which detects myocardial necrosis, myocardial fibrosis, and to some extent extracellular edema. And the signature patterns you need to be looking for are your subepicardial or your mid-wall patchy distribution. So you require overall 2 out of 2 with a positive T2 marker and a positive T1 marker to increase your specificity of diagnosing acute myocardial inflammation. So here is an example of an athlete who exhibits regions of hyperenhancement in your basal infralateral wall, as assessed in your top panel on your T2 weighted imaging. We quantified it based on the T2 mapping with prolonged T2 relaxation times, and you will appreciate on the late gadolinium enhancement, there is this subepicardial patchy distribution in the same territory. Here is a second example, slightly more unusual, in that this individual demonstrates an enhancement in the mid-anterior territory in a subepicardial distribution. We get and quantified it on T2 mapping techniques, and on late gadolinium enhancement, you can appreciate that there is this linear subepicardial streak. So we know that CMR is good for the diagnosis of myocarditis, but what about determining prognosis? Is it any good? So here we have a 21-year-old female who presented with sudden onset chest pain and a massive rise in her serum cardiac troponin concentrations. Her coronary angiography was normal, and you will appreciate that she has got extensive late gadolinium enhancement in the subepicardial and mid-wall distribution, but sparing her basal and mid-septum. And at this point, we need to be asking the question, is the presence, the distribution, the pattern, and the extent of late gadolinium enhancement important? And the short answer is yes, it is. Let me take you through some studies. So in this study by Grun, they looked at 203 biopsy-proven cases of myocarditis. They identified just over half were positive in late gadolinium enhancement, and these individuals are followed up for 4.7 years. And they showed that the presence of late gadolinium enhancement was the best predictor of mortality, irrespective of symptoms, left ventricular ejection fraction, and left ventricular end-diastolic volume. In this second study by Grani, they looked at 670 patients with suspected myocarditis with a median follow-up of 4.8 years. 15% had a major adverse cardiac event, including deaths, and 44% of their cohort had late gadolinium enhancement. And again, they also showed that late gadolinium enhancement doubles your risk of MACE. In terms of other potential information that you can derive from the contrast part of your cardiac MR study is as follows. So the presence or absence of late gadolinium. So the absence was associated with an excellent prognosis. The extent of the late gadolinium. So for every 10% increase in your late gadolinium enhancement, there is a 79% increase in MACE. The distribution, a patchy distribution, is associated with a threefold increase in risk, and the location. So if you identify septal or a mid-wall distribution, this has a twofold increased risk and was also accompanied by larger left ventricular volumes and a greater impairment in your left ventricular function. This study also demonstrated that once your ejection fraction falls below 40%, there is no additional impact of late gadolinium enhancement on your prognosis. The final study I want to share with you is the ITEMI study. In this study, the authors looked at 374 patients with acute myocarditis, and this time preserved left ventricular ejection fraction. Again, they followed these individuals up for a median follow-up of around 4 years and assessed their combined endpoints of cardiac death, appropriate ICD shocks, resuscitated cardiac arrest, and heart failure hospitalization. And again, they showed that late gadolinium enhancement is a powerful predictor of your combined clinical endpoints. But if you had an anteroseptal distribution of late gadolinium enhancement, as I've shown you in these examples, then that's associated with a worse prognosis. So overall, CMR is not only a powerful diagnostic tool, it's also a powerful prognostic tool. So what do we do with an athlete with persistent scar but preserved left ventricular function and a normal maximal exercise test? I want to take you back to this example again. So this lady who was reevaluated at 3 months, and you will appreciate that the extent of her late gadolinium enhancement has reduced. Although it hasn't completely disappeared, it has reduced. And so what do we do with such individuals? So this is how we use CMR to guide decision-making in an athlete with myocarditis. If you suspect myocarditis, do a CMR, and if you identify features compatible with myocarditis, you need to restrict these individuals from competitive sports or intensive exercise for a period of 3 to 6 months. You need to then repeat their CMR in this time period of 3 to 6 months. If you identify that there is evidence of ongoing inflammation or there is impaired LV function, these individuals should remain restricted from competitive sports or intensive exercise. So those who have a normal cardiac MR in the presence of no arrhythmias during exercise testing or Holter monitoring, these individuals can go on to compete in all sports. Those who demonstrate stable features or declining late gadolinium enhancement or normal left ventricular function, you need to make a decision on a case-by-case basis, and these individuals should also remain under surveillance. But those who have extensive late gadolinium enhancement, and that is more than 20% of your myocardial mass, and left ventricular impairment, these individuals should abstain from high-intensity exercise. So going on to my third poll and final poll, when should return to competitive sports after myocarditis be considered in an asymptomatic athlete? Is it A, after 4 weeks in individuals with a normal echo, exercise test, and a 24-hour ECG? Is it B, after 3 months in individuals with a normal cardiac biomarkers, CMR, exercise test, and a 24-hour Holter ECG? Is it C, after 3 to 6 months in individuals with normal biomarkers and a normal echo? Or is it D, after 3 months in individuals with normal biomarkers for cardiac damage and negative viral serology? Please cast your votes.
Sabi, this is very challenging. This is one of the core questions that we approach for the guidelines. So I'm pleased that you put in the poll, and I'm curious to see the attitude of our colleagues.
It's supposed to get harder towards the end of the talk.
Okay. Okay, some replies coming. Let's wait for a few more data. However, the option for 3 months after, with everything normal, seems to be much more prevalent. I think, Sabi, that we can say that more than 86% of the poll so far suggest that 3 months after, in individuals with a normal cardiac biomarker and everything else should be working, should be the right decision.
That's it.
That's
really good to hear. So the answer is B, after 3 months in individuals with normal cardiac biomarkers, cardiac MR to ensure that there is no inflammation and the extent of late gadolinium has reduced. And we also want to exercise these individuals to make sure they do not exhibit any arrhythmias during peak exercise. And this is, as you say, part of the sports cardiology guidelines. So in conclusion, CMR is the most effective diagnostic method for diagnosing myocarditis. We have the updated Lake Louise criteria, which have an excellent accuracy, specificity, and sensitivity. Lake gadolinium enhancement is an important prognostic marker in individuals with myocarditis, as I've presented based on the studies today. And the long-term risk associated with persistent scar following myocarditis in athletes is unknown and requires further studies. And it really puts the emphasis that we need to collaborate and bring this data together on our athletes post-MRI, post-myocarditis. Thank you very much.
Thank you, Sabiha. Thank you very much also for picking this very challenging topic, which is still controversial and is a reason for debate every day. So I really thank you very much.